In this lecture, I will address the gross anatomy of the lungs and respiration. The lecture is divided into two parts. In the first part, I will describe the pleural cavities. In the second part, I will describe the anatomy of the lungs. My name is Carlos Andres Suarez-Quian. I am the creator and the narrator of this lecture. Let's start with describing the anatomy of the pleural cavities. And the objectives for this first part of the lecture are listed here. I will differentiate between parietal pleura and visceral pleura and explain where the pleural cavity, the space, is located. I will describe the location of the lines of pleural reflection and the pleural recesses. Finally, I will describe the innervation of the pleura. But first, let me just state why it is that we need oxygen, that life-saving gas whose absence leads immediately to death. Indeed, there are three general principles that we must appreciate about respiration, although the specific details of these principles will be discussed in other courses, principally in biochemistry and physiology. In general, though, let me mention briefly why oxygen is required by animals. It is because we need to burn nutrients in order to obtain energy and generate our own heat. Second, the absorption of oxygen occurs through the process of respiration. We explained previously how the diaphragm and muscles of the thoracic wall help in this process. In this lecture, we will discuss the actual organ where gas exchange occurs, the lungs and its surrounding membranes, the pleura. Finally, the functions of the respiratory system are performed in cooperation with the circulatory system, the selected skeletal muscles, and the nervous system. Again, you will learn much about these interactions in the biochemistry and physiology components of the curriculum. And by the way, it is William Harvey, who lived from 1578 to 1657, who is credited with providing evidence that the blood is pumped by the heart to the lungs to be oxygenated. Then it is circulated back to the rest of the body. Before we get to the lungs, however, we need to mention briefly the components of the respiratory system. Anatomists have subdivided the respiratory system into two main areas, the upper respiratory system and the lower respiratory tracts. And I will demonstrate the individual components listed here in the sagittal section of a cadaveric head. The first component of the upper respiratory tract is the nasal cavity, which functions to filter and humidify the air we breathe, and also, as you know, to detect smells. Next, we encounter the pharynx, an open-ended tube at the back of the nasal cavity and the oral cavity. This space is a shared space with the digestive tract and will conduct the air to the larynx. The larynx is the first component of the lower respiratory tract and begins just behind the epiglottis. The larynx helps to protect the opening to the trachea and contains the vocal cords. The larynx opens into the trachea, the second component of the lower respiratory tract. The trachea filters the air, traps particles in mucus, and its cartilage helps to keep the airway open. The proximity of the trachea to the esophagus, that is, part of the digestive tube, is best appreciated in a cross-section of the neck. Slicing the neck in the axial plane, indicated by the dashed line, can produce a slice of the neck now shown on the right panel. This cross-section is oriented in a conventional way. The front of the patient is oriented superiorly, the back is inferiorly. What is clear is that, even in the cadaver, the trachea is observed as an open space. This is due to 15 to 20 cartilages that stiffen and protect the airway. Let me zoom in on the axial section and now demonstrate that the cartilages of the trachea are incomplete posteriorly and allow for distortion of the trachea during swallowing. And now observe the close proximity of the esophagus located just posterior to the trachea. I think this dissection demonstrates why it makes sense that the cartilages are not complete posteriorly on the trachea. If present, this cartilaginous skeleton could serve to injure the esophageal musculature during the process of swallowing. I have now described in very general terms the upper and lower respiratory tract. Understand that we will go into much more detail of these structures when we actually study the head and neck. This presentation simply serves to show you the path air will travel before it enters the lungs, which we now observe in this dissection, the continuation of the lower respiratory tract. On the left, I demonstrate an intact heart and lungs removed from a cadaver. It is at the lungs, however, now shown on the right, that the inspired air enters the circulation, where an exchange occurs between oxygen and carbon dioxide. Let me show you how to examine the lungs now. On the left panel, an intact thoracic cage in which the extrinsic and intrinsic muscles of the thorax were removed is shown. On the right panel, an image of the thoracic cavity after removing the thoracic cage is presented. As can be seen in this dissection, the lungs form major components of the thoracic cavity. Indeed, the heart can barely be observed. Moreover, to be precise, the lungs are located within the pleural cavity, formed by a membrane called the pleura. Let's explore what this means. The pleural cavity and the membranes enveloping the lungs and heart can be confusing when students first encounter this concept. On the left panel, I again show you the thorax after removing the intrinsic and extrinsic muscles. If we were to make a radiographic image of the axial plane at the level indicated by the hatched line, that is, the sternal angle or the angle of Louis, this is what we would see. This is a classic CT image of the chest. The body of the vertebrae, the ribs, the sternum, and structures of the heart and great vessels are clearly visible, but also a healthy lung is present and visible. Let's compare this CT image to an actual drawing to see where the lungs are present and why we were able to say that they were present in the CT image and specifically healthy. The dark spaces were actually the lung tissue itself, not the pleural cavity that surrounds the lung tissue. Remember how X-rays work. The X-ray will penetrate soft tissue, such as lung, and its image will appear black. Bone and other more dense tissues will appear either white or in shades of gray. But the lungs, specifically normal lungs, will appear black in a CT image, given that it is mostly air and will not retard the X-rays. Now that we can appreciate how lungs will present in X-ray images, let's discuss its lining, the pleura, and the space outside the lung tissue, the pleural cavity. In this drawing, a coronal section of the thoracic cage is presented. Observe the diaphragm, which forms the inferiormost boundary of the thoracic cavity, the two spaces for the lungs, and the center portion of the thoracic cavity where the heart is located. Surrounding the lungs is the visceral pleura, the connective tissue lining that is microscopic and envelops each lung. It is shown in orange in the drawing. If you trace the visceral pleura, you note that it is basically folds on itself and lines the thoracic wall. This is the parietal pleura. Parietal simply means body wall. Traditionally, artists demonstrated this relationship between the lungs and the two pleura by showing a fist smashing into a balloon. The layer touching the skin of the fist represents the visceral pleura. The layer separated by the air is the parietal pleura. And what does the air inside the balloon represent? The pleural cavity. In reality, however, the pleural cavity is not a true space. The parietal pleura simply glides over the visceral pleura, and there's only sufficient space for a few cc's of fluid to allow the two membranes to glide past one another. To describe the pleural cavity, however, I took the liberty to actually draw it as a true space. But when is the pleural cavity a true space? When the lung collapses, a condition known as a pneumothorax. Under these conditions, the fist balloon analogy really works. In a pneumothorax, air or blood, in which case the condition becomes known as a hemothorax, enters the pleural cavity and the lungs start to collapse. The visceral pleura remains firmly attached to the lung as indicated in the drawing. The space that grows is the pleural cavity. As to why the parietal pleura does not collapse also, you must understand that the parietal pleura is attached to the endothoracic fascia by surface tension forces. Indeed, we discussed this relationship previously when we described the mechanism of breathing by increasing thoracic volume. As the thoracic wall increased in volume, the parietal pleura was passively increased because it remained attached by surface tension to the endothoracic fascia, and air flowed into the lungs down its tension gradient. Having mentioned a pneumothorax in the previous slide, let me add a few more details that will help you further understand the relationships of the visceral and parietal layers to the pleural cavity, the two of which are labeled in the image. Pneumothoraxes are of two types. There's the traumatic type, indicated in the drawing, a bullet piercing the parietal pleura, for example, and the non-traumatic type, or spontaneous pneumothorax. In the non-traumatic pneumothorax, they can be primary, no known causes. Principal examples of these occur in young males who are tall and thin, or non-traumatic pneumothoraxes can also be secondary, and these occur mostly in older people with known lung problems. Diseases such as a chronic obstructive pulmonary disease, emphysema, chronic bronchitis, tuberculosis, pneumonia, lung cancer, cystic fibrosis, and asthma can all cause the secondary type of pneumothorax. Chest X-ray films of a pneumothorax are quite evident. Look, for example, at this image and note the collapsed lung in the image. Contrast this from the dark area of lung present in the CT image I showed previously. If you zoom on the image, one can observe the perimeter of the collapsed lung. Note the characteristic white line of the collapsed lung, indicated by the white arrows. If you have understood what is happening in a pneumothorax, then you should recognize this white line as the location of the visceral pleura in the image. And here are two other cases of pneumothorax. Note that in the image on the left, the white line of the collapsed lung, as shown previously, is evident. Interestingly, the lung was collapsed while putting in a central line, indicated by the red arrows, into the subclavian artery. We will discuss this complication in more detail later in the lecture. In the collapsed lung on the right, the mediastinum has shifted all the way to the left. This is a classic example of what is known as a tension pneumothorax, and it's a life-threatening condition that needs to be treated immediately by placing a chest tube into the pleural cavity and removing the air. This is the area now occupied by the right lung. By the way, do you still remember where the chest tube should be inserted relative to the rib? Another term that students often hear when discussing pneumothorax is that of atelectasis. The difference between the two terms is that a pneumothorax, as described, is the presence of air inside the pleural cavity, whereas atelectasis is a complete or partial collapse of a lung or lobe of a lung. Atelectasis can be caused by a foreign object, for example, or lung cancer, or mucus plug. The key difference between atelectasis and pneumothorax is the presence or absence of air in the pleural cavity, unless the cause of atelectasis is the pneumothorax itself. However, don't assume that every time a patient comes into the emergency room showing signs of shortness of breath and the chest x-ray demonstrating opaque material where the lungs are located, that you will encounter pneumothorax or atelectasis. Tuberculosis, demonstrated in the image, is still present in our society, and you should become familiar with its appearance in chest x-ray films. Note the flocculent material. Before leaving the description of the pleura, we need to mention that anatomists have traditionally labeled the parietal pleura in terms of its location. In contrast, the visceral pleura is simply known as the visceral pleura. As before, I show you the parietal pleura, but will now describe its nomenclature in terms of location. The parietal pleura that extends into the neck is known as cervical pleura. The parietal pleura that is in contact with the mediastinum is known as the mediastinal pleura. The parietal pleura in contact with ribs and costal cartilages is known as the costal pleura. Finally, the parietal pleura just superior to the diaphragm is called the diaphragmatic pleura. But recognize that together it is all parietal pleura. In addition, the parietal pleura folds back, reflects on itself at certain locations when the lung is not intervening between it during inspiration. The potential space created are known as pleural recesses, and the pleura will be described as a pleural reflection. Here, I point out the location of the costodiaphragmatic recess. There is a costodiaphragmatic recess associated with each lung, and where the diaphragmatic pleura reflects towards the mediastinum, the costomediastinal recess will form. Having discussed the pleura, let me now move to recognizing the surface projections of the lungs simply by understanding certain landmarks of the thorax. Prior to the modern age of imaging, physicians learned certain palpable surface landmarks to perform routine physical exams. These landmarks remain useful to understand images. The normal outlines of the pleural cavities and the lungs, for example, are still routinely used to determine the positions of the pulmonary lobes and fissures. Let me show you these surface projections now. The general outline of the parietal pleura on a thorax, as seen from the anterior view, is superimposed on the left panel, and the posterior view of the parietal pleura is shown on the right panel. The lung outline is shown in red. Superiorly, the parietal pleura projects above the first costal cartilage. Anteriorly, on the right side, the costal pleura approaches the midline posterior to the upper portion of the sternum. On the left side of the body, posterior to the lower sternum, the parietal pleura deviates to the side to accommodate the bulge of the heart. The pleura continues inferiorly from behind the sternum and reflects onto the diaphragm to course around the thoracic wall and extends to the 8th rib at the mid-clavicular line, at the 10th rib at the mid-axillary line, and the 12th vertebrae posteriorly. The lungs, the outline of which is shown by the red line, are said not to completely fill the space defined by the parietal pleura. Knowing these surface projections is not just an exercise in gross anatomy, but will be of clinical relevance once you start taking care of patients. For example, the placement of a central line demands that you clearly understand the location of the parietal pleura to diminish the possibility of further injuring your patient. A possible complication of introducing a central line into the subclavian vein is that of dropping a lung, that is, inducing a pneumothorax. You now know the anatomy of this region, and pushing too far with a needle may injure the cervical parietal pleura. A patient requiring a central line is clearly in a critical state. Inducing a pneumothorax in such a patient may be a life-threatening event. Similarly, the posterior displacement of the parietal pleura to the level of the 12th vertebrae always raises the possibility of injuring the pleura when harvesting a kidney for a kidney transplant. It was always said that being a kidney donor was much more difficult than being the recipient. Note that the kidney extends superiorly as far as the 11th rib. Hence, harvesting the kidney put at risk the parietal pleura that extended to the 12th rib. Fortunately, today, kidneys are more frequently harvested laparoscopically, diminishing the chances of inducing a pneumothorax in the donors. The last topic to address about the pleura is its innervation and blood supply. The cervical, costal, and outer diaphragmatic pleura are supplied by intercostal nerves and vessels. The diaphragmatic and mediastinal pleura are supplied by the phrenic nerve and accompanying vessels. The visceral pleura is supplied by pulmonary and bronchial vessels, but has no somatic nerve supply. There are descriptions in the literature, for example, in days before anesthesia, when lung tumors were excised and patients felt pain during the surgery, but precisely not when the surgeon actually entered the lung tissue to excise the tumor. Of course, the patient expired a day or two afterwards, given the total absence of aseptic technique. The absence of somatic nerves to the visceral pleura also explains how the pain of pleurisy, inflammation of the pleura, is a condition of the parietal pleura, not the visceral pleura. The pain sensation transmitted from conditions afflicting the parietal pleura are by way of the intercostal nerves and the phrenic nerve. The visceral pleura may also be diseased. It is just that we do not sense it because it lacks somatic nerves. This now concludes the first part of this lecture on the anatomy of respiration.